Good evening, everybody. I welcome you all to the inaugural session of the second season of Genius Junction, which is the online quiz program of our Indian Fertility Society. My name is Dr. Manjusha, and I have been given the task to coordinate the national quiz program this year. And I'm really very fortunate to be doing this. Thank you so much, Pankaj sir. Thank you, Shweta ma'am, for entrusting us with this. And also for giving us such a wonderful team of enthusiastic specialists. We have Dr. Sajjad from North Zone. We have Garima from the West, Shikha from the East, Padmaja from South, Divya from the Central Zone, and Parul from NCR. Now, before we begin, can I ask Dr. Pankaj sir to please say a few words so that we can kickstart
Yeah.
our program?
Thank you so much. Thank you so much. I think I welcome all of you here on behalf of IFS. Shweta and me are here today for the first session, the second edition, as we call it. So can you all put on the cameras, guys? Can we see your face and say hello for a few seconds? I think it's a quiz competition. You have to put the cameras on. Diksha, Gajender, Mridula. For a few seconds, we can say hello to each other. Great. That's very heartening. Very heartening. Hi, Padmaja. Hi, everyone. Honey Qureshi. Yeah, that's great. That needs some courage now. Put the cameras on. किताबें देखो पद्मजा की. There are some books behind her. This is a library. So guys, thank you so much for being with us. And I think it's a long journey we are starting today. Last year we had done this when Shweta and me, we took over in month of April. I think 3rd, 4th April, Shweta, we started with this program. And
Yes, in the
then it
month
went
of April, yeah.
month of April we started, and Shweta was very keen that we should have something like this. And I thank Manjusha for planting this thing in my mind.
Thank you, sir.
So all these quizzes are basically giving and taking away knowledge and learning from each other. I was thinking how to begin. She just told me that you have to come online. So I just got a single slide for you people. Single slide for you people. If you allow me, I'd like to share that slide. And this is the slide. Didn't have much of time. Just came back. So this is one slide I have. Can someone tell me what do you see here in this slide? Why is this picture so famous for? Any one of you? Any of the quiz competitors? You're gonna go in for a big quiz. So this is about something like a quiz only. Does someone know the story from SF Fables? No. So they say the story of a pig and a bear. So these two gentlemen, they thought that they should become like Elon Musk and Sam Altman. So they thought they'll do some business. And business had to be started. They decided what to do. So they put some money behind. They had some money with them. They put some money behind, and they thought they'll go to some village fair and open a small kiosk. So pig was very fond of little pizzas, and this guy was fond of sausages. That's the way the story started. It's just a little story. Don't interrelate and connect anything else. So they made a lot of stuff, and the mela was on. Like the mela is on now with around 40 people. Mela was on, and then suddenly there were not many people in the mela in the morning. So the bear was feeling very hungry. So he goes to the pig and says, "Can I borrow something from you?" He says, "Okay, you can take whatever you want to take." How much is this for? He says, "For one, say 1 rupee." He gives me 1 rupee. So 1 rupee comes from here and goes to him, and he gets something to eat. After 10 minutes, the pig feels hungry. He goes to the bear. He says, "I want to buy this." He says, "Okay, you can buy this. How much? 1 rupee." And the food was so delicious, they kept eating. So some chocolate, some pastry, things, they keep exchanging things. And by the time it was, the Mela had to start by around 2 o'clock. It's an afternoon fair in the jungle. To start, children came from back from school. And they came to the Mela, their whole food was gone. And they found that they only had 1 rupee between them. The 1 rupee, they have eaten everything. That's called story of a nickel. So half of the time in our lives, we are fighting over these nickels, and we use these nickels to drain ourselves. There's one thing I wanted to tell you today, that think beyond, all are the futures of the country, and I keep telling you that you guys will be leading this country into the next transformative zone. So with this, I wish you all the best, and I think we should talk about big money, big pennies, big nickels, and use our money intelligently and use your quiz forum intelligently. That's all from my side, Manjusha. Thank you so much for inviting me here. Thank you, Shweta. Thank you, Padmaja. Thank you, Shweta. And this I hand over the mic back to you, Manjusha.
Thank you so much, sir. It's really very inspiring to hear such small things which really give us life lessons. Indeed, very nice. Um, thank you, sir, for sparing time and coming to be with us for the inaugural session. Can we hear something from you as well, Shweta? Shweta, I mean,
Hello, you're referring to me?
yes.
So, good evening, everyone. Welcome back to season two of Genius Junction. Yes, it was very brilliantly conducted last season, which culminated in the annual congress at Fertivision. And Dr. Manjusha had worked very hard along with Parul and other team members. What is different this season is that the added flavor is that we have brought in a little bit of more academics and join hands with SIGs, and very experienced speakers from the SIG group would be speaking short topics, very crisp take home messages, followed by the Kahoot quiz. Now, this quiz gives three flavors. This is how we were taking it. Number one, it's more fun way of learning. Number two, it gives a very healthy competitiveness. And number three, it also makes you technologically more savvy, which was Dr. Pankaj sir's, motto when it comes to AI, technologically being sound. And the top five winners were being acknowledged. Then there will be so many zonal quiz, and Dr. Manjusha is full of brilliant ideas. And I'm sure in the middle of the season, she's going to pop us with more ideas, and then we are going to see lots and lots of participation in Fertivision, and some of you will definitely be invited. And regarding some free registrations, we are going to work out that how we are going to do for maybe the top two winners, which Dr. Manjusha will tell us. So, Dr. Manjusha, the forum is all yours. I wish you all
Shweta,
the
any
best
prize for
this
them?
season.
Shweta, you want to announce any incentive for them?
So we can actually last we can actually give the top two. Maybe I think we can do this, that the top two
Yes.
for from every quiz, we need to get their proper address and everything, and we can keep a gift for them, a small,
Yes. Yes.
we'll do that.
Definitely. This time
And
we'll
then
make it more
everybody who had
incentivized.
participated in the final for division, even in the semi-finals, everybody got a participation certificate because they had really worked a lot. So nobody went empty-hand this for division two. So Dr.
Great.
Manjusha, back to you. I wish you all the
Thank you
best. And
so
I'm
much.
sure sir will keep giving us more brilliant ideas through the season.
And where is Parul hiding? Where is Parul hiding? Parul, you're not here?
So
Yes.
No,
उसने
sir, I'm
video off
here.
आगे.
Great. All the best, Manjusha, Shweta, Parul, Padma, all the best to you.
Thank you, sir. Thank you,
Thank
sir.
you so much, sir.
Thank you.
Thank you, sir. Thank you, Shweta Mittal. Thank you. So I think now that Sir and Shweta Mittal have already introduced the program to us, so without any further ado, let's come to the first talk. So the first talk is by Dr. Shweta Gupta, and she is the convener of the SIG on endometriosis. So let's hear it from you, Shweta. Over to you, Shweta Gupta.
Thank you, Manjusha. I think, I'm really thankful you gave me this chance because I think that this whole concept has brought some newness in our SIG also. So it's a brilliant idea. And I said, okay, I mean, anything for you. Anyway, I know you because you've been my senior, but the whole thought process, combining it with a quiz and another SIG, I think it was a brilliant idea. So thank you for giving me this opportunity. And I have this small talk on endometriosis, which I'll just start. I think you can all see my slide. So
Yes, we can see. Yeah.
endometriosis is a chronic inflammatory gynecological condition and is found in about 30 to 50% of infertile women. And if we go back into pathophysiology of infertility, it's a multifactorial. The classical theory of Samson on retrograde menstruation, that is the shedding of viable endometrial based adult stem cells and mesenchymal cells which attach to the pelvic peritoneum and grow as homologous grafts under cyclic estrogenic influence. So it has a series of events which leads to ultimately what we see: fibrosis, adhesion, scarring, pelvic distortions. This retrograde menstruation blood, it gets attached to the pelvic peritoneum. There is adhesion, invasion into the matrix, and then there are growth factors, estrogen, activation of immune and inflammatory cells. There is a growth of endometriotic lesions, also hypoxia and tissue injury, and neovascularization, which establishes, and there is a survival of endometrial lesions, which later becomes the fibrosis, adhesion, scarring, pelvic distortion, and the patient may present with infertility and pain. So, just summarizing, there are many factors, many ways where endometriosis can affect the fertility. There can be mechanical factors, pelvic adhesions, anatomical distortions, myometrium, dysperistalsis. There can be chronic inflammation, peritoneal, which can affect even up to oocyte quality, embryo transfer. There can be sperm function motility. There is also endometrial receptivity where there is hormonal disturbance, estrogen predominance, and progesterone resistance. Then there can be effect on the because of the endometrioma. There can be ROS and inflammation mediated damage. So there can be multiple ways where the pelvic anatomy and the physiology gets affected. So our main topic is ovarian reserve, and there is an impact of endometriosis on the ovarian reserve. Now, the endometriosis can be many types. We know there is one is superficial pelvic endometriosis, which is found in about 15 to 50% of women. And there are lesions which we see laparoscopically, like red, black, or white colors, which represent the progression of the disease from vascularized active lesion to advanced disease to its quiescent phase. And such presence of ectopic lesions on the peritoneum reduces the chances of spontaneous fertilization threefold. We also see endometrioma, which may be present in up to 44% of endometriosis, and they present significantly lower serum AMH levels, with significant reductions reported among the presence of large endometrioma, and especially if it is bilateral. It has been noted there is a faster decline in serum AMH levels compared to their age matched counterparts. And these features are attributable to several complex interacting factors, including increased primordial follicle activation that gives OMA this inherent characteristics of increased ovarian aging. Now, endometriomas are expected to cause a significant damage to reserve already and function already before surgery also. These cysts may have a toxic content that can lead to unfavorable effects such as increased oxidative stress, increased fibrosis, loss of cortex specific stroma, smooth muscle cell metaplasia, and some oxidative stress components such as iron derivatives can easily diffuse through the endometrioma wall. Ovarian cystectomy, that itself has an irreversible damaging impact, and the classical technique of laparoscopic ovarian stripping is the injury can be in up to 10 to 15%. Women operated on for ovarian endometrioma showed a reduction in AMH level of 1.54. So ovarian response to stimulation is also lowered in operated gonads. Iatrogenic injury, I think it's a very, the laparoscopic surgeons are quite fond of doing surgery, but it is very important that they are very careful and avoid unnecessarily damage to ovarian tissue. So excision of endometriomas can lead to decrease in ovarian reserve in AMH, and especially if it is a bilateral laparoscopic surgery. So women who undergo surgery for bilateral endometriomas experience menopause at an early stage age and have a higher likelihood of post-surgical premature ovarian failure. Recurrence, even though if you have done a good job, this is a chronic condition with a significant tendency to recur. Now, the disease has shown to recur in 22% of women at 2 years and about 40 to 50% at 5 years. So, roughly about 10% rate per year. And all types of endometriotic lesions have a high rate of recurrence after conservative surgery. So, recurrence is a substantial problem in the clinical treatment of endometriosis. Whenever we do any surgery, we should try to preserve ovaries. Ovarian surgery is not always necessary, and preventing surgeries should be the first step in protecting the ovaries. If surgery is needed, keep it minimally invasive, that is, rather than removing the bigger chunk of cyst. No matter the complicated nature of surgery, the goal is that fewer ovaries are removed unnecessarily, improving the lives and reproductive outcomes in young women. So this is a paper which said that the risk of iatrogenic injury is among the most important factors in the context of fertility preservation, along with the age and individual reproductive goals. So in case of endometrioma excision, evidence overwhelmingly demonstrate that negative impact of surgery on ovarian reserve with a significant reduction in AMH. If it's a unilateral, 30% can be there up to, and if it's a bilateral, 40 to 4%. So, good counseling regarding fertility preservation is also a new thing which has come up. And for to have a realistic chance of live birth, cryopreservation of 10 to 15 oocytes in women younger, less than 35 years, and over 20 for those more than 35 years. Also, fertility conserving surgical methods to reduce the likelihood of post-operative iatrogenic diminished ovarian reserve. In AMH, as I've already mentioned, it gets lowered post-operatively up to 18 months and more pronounced if it's a bilateral. Now, what about the oocyte quality? The literature is still under debate. Some meta-analysis says that it does not affect embryo morphology. It does not have any, it still can have the good quality embryo rate, cleavage rate, embryo formation rate. But then there are studies, and the result is very controversial because those meta-analyses have a high heterogeneity of the studies. One recent study says, which was done using time-lapse technology, observed altered relative kinetics in embryos from patients with endometriosis, supporting poorer embryo quality. Follicular fluid, an altered systemic and peritoneal immune and inflammatory profile that characterize women with endometriosis, has been proposed to directly influence the follicular fluid composition. So we can even have altered levels of pro-inflammatory cytokines and growth factors that have been reported in the follicular fluid of women with endometriosis as compared to controls. So this imbalance in the ROS and antioxidant systems in the oocyte microenvironment could promote abnormal oocyte development, causing DNA damage, which could result in lower oocyte quality. Impaired ovulation. So the clinical data concerning spontaneous ovulation rate in these women is poor but controversial also. Prolactin levels are significantly higher in women when compared to those of women without endometriosis. And hyperprolactinemia prevents LH pulsatility and interferes with hypothalamic function by blocking estrogen receptor, thus producing anovulation. Another potential cause of ovulation failure is LUFS, luteinized unruptured follicle syndrome, in which the dominant follicle undergoes luteinization but fails to rupture at or release the oocyte. There is altered pattern of estrogen and progesterone secretion leading to abnormal luteal phase may also compromise ovulation in these women. Endometrial receptivity. Again, the implantation rate is clearly diminished in women with endometriosis during both natural and ART treatments. Now, the data from the clinical studies suggests that endometriosis leads to implantation defects, implicating the endometrium is still conflicting, and there are defective implantation which could be due to reduced endometrial receptivity or decidualization capacity in these women. There is functional dysregulation of steroid hormones, upregulation of estrogen, so estrogen dominance, and also the progesterone receptor resistance. All these play a very important role in impairing endometrial receptivity in these patients. Adenomyosis. A lot of times we see the endometriosis and adenomyosis often coexist. And again, this also has a negative impact on the pregnancy rate, higher risk of miscarriages following ART, and adverse pregnancy and neonatal outcomes. So, how do we manage? Now, this is a beautiful chart which shows that is a need of individualized and multidisciplinary approach, which is dependent on the age, duration of fertility, suspected level of impairment, any additional infertility factor like male or tubal, concomitant endometriosis associated pain. Now, if you're talking about fertility, the very important is either surgery or the medically assisted reproduction. Medical treatment is not recommended. So, apart from these two are important by a large way of treating it. And very important is this new thing, endometriosis fertility index, which has come up, which is this scoring takes not only the historical features like age, years of infertility, prior pregnancy, but also what we find in laparoscopy. So, surgical factors and like a least function score, AFS endometriosis score, and then you do the totaling and you give a very validated, reproducible, cost effective scoring, which tells which helps us in counseling the patient regarding their chance of becoming pregnant after surgery. So if the scoring is better, then they have a better chances of achieving the pregnancy. So with this all scoring, there is important that there is a personalized fertility counseling, age, extent of involvement, current ovarian reserve, previous impending surgeries for endometriosis, and all this together we individualize the case. So again, this is the same, which is showing what is the need, the future fertility or immediate fertility, what is her egg reserve, what she wants to do. So depending upon the case scenario, we make a treatment plan. Just few slides about the ASHRAE. There are some changes in the new ASHRAE, which was published in 2023, that there is no clear-cut protocol. Both protocol, agonist and antagonist, are equally good. Earlier days, we used to use ultra-long protocol for endometriosis, but it is no longer considered or recommended. So women with endometriosis can be reassured regarding the since the recurrence rates are not increased compared to those women not undergoing ART. Um, and then there is extended administration of GnRH agonist prior to ART treatment to improve live birth rate in infertility women is not recommended. Uh, very important that clinicians are not recommended to perform surgery prior. The earlier we used to think that we have to remove the cyst and then the patient should go for ART. So there is no clear cut benefit, and the risks are there. So this is a picture which showing there are different risks with the surgery. And so nowadays, if you can manage without endometrioma surgery, you can straight away go to the ART. But there are conditions if the patient has pain or if you are not able to see the follicles and accessibility of follicles is a problem, then of course the surgery is recommended. So the question is, when do you consider repeat laparoscopy? A lot of times we see the patient who already had a laparoscopy and again come. if there is a rapid growth in the size of endometriotic cyst, if there are suspicious features seen on ultrasound MRI, if there is inability to access the follicles in normal ovarian tissue, if there is excessive pain that can be attributed to the cyst, or if there is a risk of spontaneous rupture of cyst. Very briefly, I'll just mention about the ovum freezing and ovarian tissue cryopreservation and fertility preservation. There are oocyte cryopreservation, embryo cryopreservation, ovarian tissue cryopreservation. There is a lack of clinical consensus, but it is recommended or advisable in women with large or bilateral endometriomas, previous ovarian surgery. And the success rate of ovarian cryopreservation vary based on again age, ovarian reserve, and the surgical history. If the patient has partner and married, embryo freezing. Ovarian tissue cryopreservation is again another valuable option for patients who cannot undergo controlled ovarian stimulation for urgent surgery. And there have been a lot of papers on this. What is the number for which is good enough for embryo freezing? The clinical live birth increased as the number of oocyte used per patient rose, reaching in 89 using 22 oocytes. So if we have a younger lady, the less number is okay. But if the age is more, then obviously we need a more number of eggs to be frozen. Ovarian tissue cryopreservation, it was earlier experimental. Now it has become standard treatment and few centers have started doing. But again, it requires two surgical procedures. The first is to harvest the ovarian tissue, and the second is for transplantation. So, but it is, as you can see in this picture, there are smaller tissues. The ovarian tissue is fragmented and cut into smaller pieces, and then it is put into the cryopreservation by vitrification. It's a good way to start future fertility and hormone for the future fertility and hormone production. Whole ovary. Now there were few paper on the whole ovary, which is the cryopreservation of whole ovary followed by vascular anastomosis of the ovarian pedicle has been suggested to decrease ischemic injury and provide a suitable follicular reserve as well as longer lifespan of the transplant. But technically challenging to freeze whole ovary. Optimizing freezing and thawing conditions for the intact organ will not be achieved easily because of the large size and the composition of various cell types. So not routinely done. I think I'll move to this slide, which says that when you transplant back the ovarian tissue, it can be done into the ovarian fossa, that's called orthotopic sites, or it can be done at a distance, which is heterotopic sites like arm subcutaneous. But almost all pregnancies and live birth have been reported at an orthotopic sites, which continues to be the first choice when applicable. Now, there are some papers, and it has been found that when you're doing the endometriomas, you can preserve the ovarian tissue, and healthy ovarian cortex fragments might be isolated and cryopreserved during the surgical removal of endometriomas. So, with that, I end that it's a chronic inflammatory disease seen in about 30% of infertile patients. It has definitely detrimental effect on fertility. It is multifactorial. Timely fertility management is important. So increased awareness is there, should be there. Minimal fertility sparing surgery should be done. There are options for fertility preservation so that, and a good counseling is required for long-term reproductive plans and providing a realistic assessment of the advantages and potential failures. Thank you.
Thank you so much, Shweta, for this very, very enlightening and crisp talk that you just gave us. Can I ask Pankaj sir to give a few comments on this? Yes, sir. Dr. Pankaj sir, would you like to please? Sir, आपको unmute
Yeah,
करना
it's a very lovely talk, very lovely talk. And I think the way you've covered about the ASHRAE guidelines of 23, you have summed it up so beautifully. Only one thing, probably, I hope I didn't miss it, that you can tell them about the complication of going into an endometrioma. It's very tempting. It's very tempting. When we
Mm,
were starting our careers,
mm,
but at many centers in the beginning, around 25 years back, we learnt our transvaginal aspirations by doing endometrioma aspirations. They said endometrioma tumhara. As a trainee, na, like episiotomy, endometrioma is yours.
mm,
We never realized it. We kept, when we were beginning our careers, they said, any PCOD fulguration is yours. Just keep fulgurating the ovary. Endometrioma,
mm,
keep aspirating. But now both the things are gone into some dispute. Am I right? I mean, that's the way we look at it. We don't,
mm,
we keep
mm.
don't, we don't keep fulgurating the ovaries anymore. Cortex can be harmed. Same way we don't aspirate endometrioma. So I think you can talk about bit about that, Shweta, that endometrioma is what to do in case you have gone inside an endometrioma, what you should do, and when to leave it. That you can just cover in case possible.
Yeah, so I think that ASHRAE guideline does have, which sir has picked up very nicely, but I think because of the lack of time, I just,
Yes, I understand.
yeah. So there was a thing that if you aspirate, you shouldn't, but inadvertently, a lot of us, we end up touching it or picking it, then we should definitely cover it with antibiotics and do a close monitoring. So first try to avoid the endometrial cyst, pricking it. But if at all it happens, then give antibiotics and also follow up closely that patient post-operatively.
Correct. Thank you so much, Manjusha, for this opportunity. Thank you. I really enjoyed myself. Thank you.
Thank you so much, sir, for
Thank you. Yeah.
encouraging us.
Hi, Priya. How are you?
Good, sir. Very good evening, everybody.
Thank you so much, Shweta, for this wonderful talk. The next talk is by the Kalyan Tuberculosis, the very learned and forever energetic and bubbling with great ideas we have with us. So over to you, Priya, to talk on tuberculosis enigma. Can I ask Shivam to give screen sharing rights? And by the time Priya is setting up, acknowledge the presence of our Vice President, Dr. Ritu Khanna ma'am, Geeta Khanna ma'am, and I can also see Dr. S.P. Jaiswal ma'am. I can see, it's really very heartening to see very senior people coming over to encourage us. Thank you so much, ma'am. So much. Really, really very exciting. Thank you. Over to you, Priya.
Yeah. Thank you very much, Dr. Manjusha, for this wonderful opportunity, and thank you very much for the wonderful work that you are doing by the Genius Junction quiz. This is really something which has enthused all the generation next, and I know that all of them, they look forward, and this new cherry on the cake which you have added. So not only are they able to showcase, but they are also able to get new nuggets of information. So, I'm very happy to speak on diagnosing genital tuberculosis. This is a topic about which we have spoken a number of times. But I think many of the juniors who are right now undergoing training, or they are in early stages of their career, many times because of the geographical variation in the prevalence of tuberculosis, they may not have seen as many cases. And there are some areas wherein the trainees, they are exposed to a lot of tuberculosis. So I thought I should give them some message which they will be able to carry through, because our generation has miserably failed to end tuberculosis. So we were supposed to do it by 2024, 6 years ahead of the national goal, but we have not been able to do it. And so now this generation next needs to be equipped with our experiences and knowledge. So, this presentation cannot be started without thanking all the people who have done a lot of research on this subject, and they have published it. So, right from Dr. S.N. Basu to Dr. J.B. Sharma, Abha Madam, Dr. Sonia, Dr. Alka, and Atul Kumar. And so, all of these people have published their findings on genital tuberculosis, and this has added to the knowledge that we know. And as Newton said, This is an ancient scroll which says that if I have seen further, it is by standing on shoulder of giants. So these are the shoulder of giants who they have allowed us, they have, given us the privilege to look into their work and understand. And whatever I speak today is because of the knowledge that I have learned from them. This comes on the background of our large published series in British Journal of Obstetrics and Gynecology 2 years ago. We are very proud to have published the largest series in the world on genital tuberculosis and infertility. The findings of this paper I shall discuss with you. Those who are interested in getting this paper can send me a WhatsApp on 810-900-2618. I'll be very happy to share the full text. Unfortunately, it's behind a paywall, so you'll be able to get the abstract, but not the full text. I'll be very happy to send the send the paper if you send me a WhatsApp. So I basically want just 4 things from this lecture. First is that let us please understand that there is no gold standard test for genital tuberculosis. Also recognize that there probably never will be. And avoid overdiagnosis and unnecessary treatment. So when we were growing up and when we were in our early stages of career, a lot of patients were being prescribed anti-tubercular treatments because molecular diagnostic tests were not that advanced. Because the burden of the disease was a lot, so many patients would get empirical ATT. Also, the understanding of the features of the disease in laparoscopy was not very clear. So there were regions wherein if the patient is infertile, she would be prescribed anti-tubercular treatment without even bothering to find. Sometimes flimsy, findings such as positive Montauk's test and the patient receives 6 months of ATT. Thankfully, these examples have now dwindled because now patients are also aware. They ask their doctor, what is the prescription that you have written? What are these medicines for? But there are still some pockets where this is going on. And with the rampant or not rampant, but cases coming in of extended drug resistance, of multi-drug resistance, and the very limited availability of the second line and third line ATT, it's very important that unnecessary treatment should be avoided. Third is we have to diagnose early before the sequelae set in. The characteristic of this infection is the fibrosis and the end arteritis. So the inflammation at the end of the small arteries leads to a fibrosis, and this leads to very typical findings or the sequelae which do not happen in other diseases. And the last one is the role of hysteroscopy and laparoscopy in timely diagnosis. So first we'll take why this is an enigma. Why is it so difficult to diagnose? We'll put the pieces together and try to find out the natural history of the disease so that we are able to pick up the disease in the active phase before the fibrosis sets in. We'll also look at the rational interpretation of diagnostic tests. Dr. Manjusha will remember the time, how the pendulum swings. So we were in an era where there was a lot of enthusiasm for the PCR-based test for tuberculosis. Then we understood that it doesn't work. And now we are at a stage where we have gene experts. So we now understand we have a test with better sensitivity, better specificity. And we are also able to put the pieces together and not rely on just one test. And the way ahead, that is a scoring system. So, of course, India is one of the high burden countries, and almost half of the patients of genital tuberculosis will have infertility. But remember that half of the patients with genital tuberculosis may also conceive. So just the fact that she has tuberculosis does not mean that she is infertile. There is an affliction to different degrees. I have had a patient wherein she had a biopsy confirmed granuloma. She had typical findings on laparoscopy, but the tubes were patent. We started her on ATT. There was a shortage of drugs at that time, and she went home. And by the time she came back, she had a positive pregnancy test, and she just delivered 3 days ago. So it's very important for us to remember that infertility in tuberculosis is not absolute. And very big thing is that these patients are also very prone to ectopic pregnancy. So even if you have treated a patient of early genital tuberculosis, always tell her about ectopic precautions. Now, it's always secondary to primary infections in the lungs. It's always hematogenous. And that is why whenever you see the sequelae, it will always follow how the blood flows. So how the blood flows into the uterus is from the sides through the uterine artery. So in advanced genital tuberculosis, you always see fibrosis of the lateral walls of the uterus. So a triangular cavity becomes a T-shaped cavity or a Y-shaped cavity because there is a continuous inoculation from the both sides from the uterine arteries. Similarly, there's blood coming in from the ovarian vessels, and this also causes Y-shaped and T-shaped uterus, and there is fibrosis at the top. Always remember it's a bilateral involvement of fallopian tubes. So if a patient has tuberculosis, it's very unlikely that the other tube is spared. The extent of involvement may be different, but it's always a bilateral involvement. So in all cases, tubes are affected, but the endometrium is not affected in all the cases. Now, all of us take the sample from where? We take the sample from the endometrium. So if you take an endometrial biopsy in a patient with active genital tuberculosis, which is confined to the tubes, you will not get a positive test when you sample the endometrium. Unfortunately, there's no way for us to go inside the endosalpinx and sample it yet. Eventually, I'm sure there will be, but right now there isn't. So, but the vice versa is very important. In case you see endometrial involvement, in case your biopsy comes out positive in culture, or you see typical tubercular granulomas, the tubes are always going to be involved because endometrial involvement is always secondary from the tubes. It's never that it goes up from the endometrium, it always comes down from the tubes. So the typical features of hysteroscopy, features of tubercular endometritis are also best seen near the ostia. Why it is an enigma? Because the patient does not have any symptoms. It's a disease with very few bacteria. So unlike the lung lesions, you have very few bacteria. Endosalpinx, we discussed, is not amenable to repair, and the endometrium is going to be shed off every single month. So remember that don't rely on one test, and the disease may be present even if all the tests are negative. This, I think, is very, very important. So don't be like these 6 blind men relying on one single test, one single symptom, one single factor in the history. Try to open your eyes and look at the bigger picture. So don't forget to take a good history. In fact, in our unit, we pay a lot of attention to which area of Madhya Pradesh is the patient coming from. There are some extremely tubercular endemic districts in our state, wherein from our own data of tuberculosis, we have decided that we found out that there is a higher prevalence when patients come in from these districts. If there is a family history of open tuberculosis of the lungs and the patient was exposed as a child or was in close proximity, all these will add up. So when you see subtle findings on laparoscopy and you find these things in the history or in the region from where they're coming, try to put everything together. And we will talk about the scoring system which Dr. J.B. Sharma and his group is developing at the end. And we really hope that all these factors also can be included. Another thing is that whenever you are taking the history, we always associated tuberculosis with scanty bleeding during menses. But in our experience, many patients have menometrorrhagia. That is because when the bacterium is actively dividing and there is an active endometritis, the patient actually has heavy bleeding. One very characteristic symptom is after you have done an endometrial biopsy or you've done a hysteroscopy and laparoscopy and taken a sample, the patient continues to have erratic bleeding for 1 or 2 months after that. This is something which is not described anywhere, but we have looked back at all our patients, and this is something which we found in many of our patients whom we did a laparoscopy in active tuberculosis. So coming to the diagnostic tests, we have direct and indirect tests, and the third and very important is demonstration of the features on laparoscopy and hysteroscopy. Now, if you were to see a patient with chickenpox in your OPD, you will not bother taking the fluid from that vesicle and culturing it, isn't it? So in the same way, when you see characteristic features on laparoscopy, you see tubercles, you see caseation, you see a typical Asherman syndromes, many times because the endometrium is shed off, bacteria are deep-seated, they may not yield in the test that you do. So please give also weightage to the frank features of the disease on laparoscopy and hysteroscopy and don't rely only on the test. But in our own series, we had a very good number of patients wherein we had positive tests and no features on laparoscopy or hysteroscopy. So for us, findings as well as tests are very important. We send the test of histopathology, we send culture, we send smear. we send histopathology for all our patients who undergo a diagnostic histolaparoscopy, even if there is no history and there are no family history or no history of exposure. So the typical tubercular granuloma, it's very rare to find it in the tube. It's very rare to find it in the endometrium. So this section is from one of our patients where we had sent the salpingectomy specimen. Why it is not seen very nicely in the endometrium is because endometrium keeps on shedding every month. So before the before the granuloma, it takes 3 to 4 weeks to form, but before that, the endometrium has shed. Indirect test, whether it is TB Gold or Montouk's test. So don't get carried away by the name TB Gold. All of us are women, we love our gold. But TB Gold is just a little better form of Montouk's test. So what Montouk's test does is the measurement is a little subjective. So this is a very objective test. So how much interferon gamma is being released by the activated monocyte macrophages, it is quantifying. So quantification of the interferon, that is nothing but quantiferon TB Gold for you. So it's a glorified Montouk's test. We don't use it very often because all of us are in high endemic area. We are all exposed. We have all received the BCG vaccine. So many of us may give a positive test even if we are not diseased, we may be infected. So this is the most important part, which I want all the youngsters who have joined to take it with them. One is the concept of latent genital tuberculosis. Second is the concept of the inflammatory phase of genital tuberculosis. And third is the concept of fibrosis setting in. So this time where you already have fibrosis wherein endarteritis has happened. And now most of the sequelae are seen. But your aim is that you want to detect it in the inflammatory phase. Whether you want to detect it in the latent phase is very debatable. So latent phase means the bacteria is in the uterus, it is in the tubes, but it is not exciting an inflammation in the genital tract. But it is there. So I think all my colleagues who are from my generation would remember the time that you took an endometrial biopsy and TB PCR came out to be positive. And you felt very happy that you have diagnosed the bacteria and now you want to treat the patient, but she had no symptoms and absolutely normal findings on laparoscopy and hysteroscopy. So these were probably patients with latent genital tuberculosis. If the patient has a good immune system, the bacteria can apparently coexist without producing a disease in some women. But when your immunity drops, also when you start them on IVF for certain protocols which increase estradiol, and this is something which I learned from Dr. Sonia Malik. She has shown a couple of papers wherein whenever the estrogen rises, there is a change in the immunity, in the local immunity, and the latent disease also tends to flare up. I've seen this myself. I can't, there is less time, but I can't resist telling the story. I had finished my fellowship from CMC Vellore, where I had seen not a single case of tuberculosis in the 2 years that I studied. I came back to Indore, and the first patient that I did a stimulation on, she failed in her first cycle. And in the next cycle, her endometrium just would not grow. When we did a hysteroscopy, we found that she actually had Asherman's, and this happened between the first and second IVF cycle within 3 months. And I was really shocked because in that stage of the career, you are really looking at every patient with a lot of care, and you're looking back at what you have done. So what had happened is this patient was a patient of tuberculosis. We had done a laparoscopy. We did find certain findings, but because I was not aware, I did not start her on ATT. For a tubal factor, we would always do a IVF. During IVF, I think the estrogen increased, the disease flared up for whatever reason, and then she ended up with Asherman's 2 to 3 months later when we attempted her frozen embryo transfer. So yes, in some patients, the latent disease can actually flare. How frequently it happens, we don't know because there are very few papers about this. So this is what we have learned, and this is what our paper, which I'll discuss eventually, explores. In latent genital tuberculosis, there are no symptoms. The Montouk's test may be positive because this patient has an infection. The body has been exposed to the tubercle bacillus. So whenever you inject tuberculin, the monocyte macrophages will secrete interferon gamma. HSG, laparoscopy, histopathology, everything will be normal. TB PCR may be sometimes positive, not always. But when the bacteria start dividing in the inflammatory phase, this is when you get positive tests. So you do get histopathology positive, smear positive, sometimes even culture positive. So please don't forget to send culture. I'll show you my series wherein we had 17 patients wherein the culture was positive, but everything else was normal. Patent tubes, normal laparoscopy, normal hysteroscopy. So had we not sent a culture, we would have missed these 17 cases and eventually it would have progressed. In the late and fibrotic phase, you will get a lot of signs. So what are the signs? You will see images of HSG, you will see laparoscopy typical findings, but you may not find the test to be positive. Now, why is that so? Because already fibrosis has happened. The bacteria have become submucosal. So when you scrap the surface, there's nothing, there's no bacteria. Already there has been a fibrosis. So don't be surprised if you see a patient of tuberculosis with typical findings, but TB PCR, AFB smear, culture, everything turns out to be negative. Okay. So active genital tuberculosis, you will see endometritis. Early phases, you will see some findings on hysteroscopy like focal and diffuse hyperemia, polyps, and adhesions. But remember that chronic endometritis is not just caused by tuberculosis. There are multiple other bacteria which cause endometritis. It could be mycoplasma, it could be chlamydia, it could be so many other organisms. Now we have better molecular tests. So just the presence of these findings doesn't mean you start your patient on ATT. So this is how focal hyperemia and periosteal polyps look like. This is how diffuse hyperemia looks like. Micropolyps, now all of us regularly look for, and we are aware about this entity. So what we should be doing is, please schedule your hysteroscopy and laparoscopy in the late proliferative phase. Don't do it just post-menstrually. If you do it post-menstrually, there's not enough endometrium to visualize the changes in the of micropolyps and focal and diffuse hyperemia. Second thing, please do it in a vaginoscopic manner. Don't dilate the endometrium, don't dilate the os, and then there are endometrial fragments all over, because these are subtle findings. So try to do it vaginoscopically with a smaller hysteroscope. In the late phases, you'll find adhesions, you'll find T-shaped and Y-shaped uterus, you'll find intrauterine adhesions. Also, if you look at laparoscopic findings, you will have, this is a very typical, case where you actually see caseation which is pouring in from the ostia. In the laparoscopy in the early phase, these are the typical findings. Here you can see the entire bowel, the entire peritoneum, everything is studded with tubercles. Late features, just one feature that I should tell all of you about, that is the block at the junction of isthmus and ampulla. This is very typical, and it is found in many cases of tuberculosis in our series which we have published. And why this is important is, if you see a cornual block, it can be because of multiple reasons. A terminal block can be because of chlamydia, but a block at the junction of isthmus and ampulla is only and only because of tuberculosis. I don't know how much time I have. I'll just finish this. And if I have time, we can go through the our paper findings. Dr. Manjusha, do I have time? Okay, so I'll just quickly take you through the findings of our paper. We found the top 3 findings on hysteroscopy were periosteal fibrosis, pale endometrium, and micropolyps. Laparoscopic findings, the top 3 findings were abdominopelvic adhesions and perihepatic adhesions. Now, these are the findings which we have seen. Look at C. C is a very typical case of endometrial tuberculosis. You will see this very characteristically, the peaks are pale. So the endometrium is polypoidal and the peak of that polypoidal endometrium is pale. And this is very much seen around the ostia. Once you see it, you can't miss it. So these are our findings from different patients whom we have seen. These are the laparoscopic findings which we have published. If you look at E, now, whenever sometimes you inject the dye, sometimes there is a significant tubal thinning at the ostia. And sometimes there is even a formation of a tuboperitoneal fistula, and that thin part just gives away. This is also seen characteristically in tuberculosis. So if you find this, please make sure, I won't say that this is tuberculosis, but this finding is seen more commonly in patients with tuberculosis. Extravasation of the dye. This is again very important. Whenever you see that the tube is becoming blue, this again shows tuberculosis. So the top three findings in laparoscopy are abdominopelvic adhesions, perihepatic adhesions, and tubercle. The top three findings in hysteroscopy are periosteal fibrosis, pale endometrium, and micropolyps. And this is the statistical analysis of highly diagnostic suspicious tests. So highly diagnostic are adhesions, asthemoampullary block, tubercles, and tubo-ovarian mass, also hydrosalpinx and complete tubal destruction. Suspicious are micropolyps, perihepatic adhesion, and encysted fluid. So I really wish that this paper can reach more and more people. So I'll be very happy to share this paper with you. You can send in your request to Dr. Manjusha, and I'll be very happy to share the full text with her. She can share it on the group, or she can have it mailed to everybody who has joined. Dr. Manjusha, do I have some more time, or we are done? You're muted.
Yeah, it's such a pleasure listening to you, Priya. If you can show us a little more in about, say, another 2, 3, 4 minutes.
Sure. I'll just finish in 1 more minute. So one last word about using MUM1 as a novel marker. So we started using it 6 years ago because we found that many times the endometrium looked inflamed, but we did not find any inflammatory cells. So MUM1 is a stain for plasma cells. Even a single plasma cell in the endometrium gives rise to a positive MUM1. So this is the study which we have published in a Fertility Science and Research Journal. Here we have only correlated it with the genital tuberculosis, but now we have extended it to all the other causes of endometritis. You can read this paper. So we found that it has a good negative predictive value for endometrial involvement in tuberculosis. So if not even single plasma cell is present in the endometrium, then endometrial infection due to tuberculosis is unlikely. But tubal involvement due to tuberculosis can happen, right? So this is something which we are looking at everybody, so that we can collate our data and we can work together. The summary is that don't rely only on tests, but do not forget to send the tests, diagnose early, and please treat completely. Thank you so much.
Priya, it's indeed very, very illuminating to listen to you, and you have such a and I'm really impressed when it was learned that you have published such a high journal. I mean, I'm really speechless at your achievement and how you conducted it. You have summarized all that into a capsule and
I'm not audible.
benefit from your knowledge. We have a couple of questions in the chat box, and can I request Dr. Sajjad to please take the questions? Priya will just
Yeah,
give you
yes, ma'am.
2 minutes. Please time to answer these questions.
Yes, good evening, ma'am.
Sajjad, sir? Yeah.
Yeah, there's a question from Dr. Sharma that uh, on TB PCR report, can we start treatment of TB tuberculosis? So we should start the treatment of tuberculosis on TB PCR report.
What's your opinion?
I have two things to say. One is that we are now sending a gene expert test instead of a TB PCR test. Gene expert is a point of care testing. It is completely automated. Unfortunately, it has a very good sensitivity and it has a very good specificity. TB PCR used to be sensitive, but it used to not be specific. What
Okay.
happens with the gene expert is that you get a positive test less frequently than you do in TB PCR. Unfortunately, gene expert has not been standardized, or the preparation of the solid tissue which we sent is not done very well in most of the private labs where we send gene expert. So most of our samples turn out to be negative. In my series of more than 4,000 patients, I've had only 2 gene expert positive. This is because the solid tissue has to be ground properly and then it has to be put in for the test. Starting treatment with TB PCR, there are two things. One is that it could be a latent genital tuberculosis. Features on laparoscopy, bacteria. So sometimes we may be over-treating. Second thing is that the government mandate is that in extrapulmonary tuberculosis, you can start treatment on clinical basis. So even if the TB PCR is negative, but you have good clinical reason to suspect that this patient may be tubercular, you are free to start the treatment, but you have to notify the disease and you have to make sure that this patient is registered in the portal so that she gets that amount of 500 rupees per month from the government, and you also get an incentive. If you don't register, then it's a offense.
Yeah, ma'am. There is one more question from Anjali Patil. That which lab does DICE test?
So DICE is currently being offered by LifeCell. They're looking at 11 different pathogens in the panel.
And how much is the approximate cost, Dr. Priya?
I think it is costing around 4,000 to 5,000 per sample.
Okay. And how do you send it for the sake of everybody around?
So what happened is once we started doing MUM1, so many patients had no features of tuberculosis, no family history, but their MUM1 was positive. So more than 4 cells positive for MUM1 is considered positive. There were patients where we had 25, 30 cells. So we found two more correlations. One is patients with adenomyosis have positive MUM1, probably because with adenomyosis there is some sort of impaired inflammatory state of the endometrium. Second is we found that some patients have infections with different bacteria which are not very amenable to culture, like atypical mycoplasma, like chlamydia. So DICE looks at molecular footprint of these organisms. And once we started doing DICE, we were able to understand why MUM1 is positive. So MUM1 was positive in tuberculosis, MUM1 was positive in polyps, MUM1 was positive in adenomyosis, and fourth MUM1 is positive in endometritis due to these other organisms wherein we sent for DICE test.
There is one more question from Parvati Devi Tata Pudi. What is the difference between TB PCR and Gene Expert?
They're the same tests, but in TB PCR, it is all done manually. In Gene Expert, the sample goes in the machine. There is minimal interference from anybody, and the machine gives you the result. It's a point of care testing. But the sample processing is very important. So standard labs, which are the national standard labs, will do it very well. They'll do it free of cost for your patients. They will grind the sample and then they will put it in the Gene Expert. So if you do a Gene Expert properly, the sensitivity as well as specificity is very high. In my series where we were sending Gene Expert to private labs, our sensitivity and sensitivity was very poor. Imagine just 2 patients positive out of 4,000. Very, very poor.
So excellent talk and wonderful talk from you. It and so informative for all of us. Thank you.
Thank you. Thank you very much for this opportunity. Thank you, Dr. Manjusha.
Thank you, Priya. Thank you, Dr. Siddharth. And thank you, the audience, for being such a proactive one. And I think now we can move on to quiz part. And may I request Dr. Padma and Shivam, please could you start with the part of it?
Manjusha, you are not audible.
And we're really thoroughly
You are not audible.
Yeah, ma'am. Manjusha, ma'am, you are not audible.
You need to come close to the computer.
Yeah. Can you hear me now?
Yeah, better.
Yeah. Well, I was just
I think the Wi-Fi bandwidth is also varying, so we are getting it like waves. So some waves. Yeah. Thank you, Dr. Manjusha, and welcome everyone to the quiz on Kahoot. Shivam, you're available?
Yes, ma'am.
Yes. So you're going to show run because this is a new season that we are starting. Can you just go through it once? So you can see you need to open your Kahoot app preferably on the cell, on another device, or on the same computer in another window, and you have the pin there, 6547144, and then you press enter.
Requesting everyone to please enter your nickname as your phone number so we can identify you later.
Yeah. So we are having names, but please put in your phone number there. Yes. And then please put in your, okay, go. So of 64 people, we are starting to get in the numbers. That's great.
I think by the time these guys are checking in, Dr. Padmaja, can you please tell them how to click and how to start off once the questions go on air?
So the questions are of multiple choice, and you will have, I think we've given only 4 options for each question. You will have 20 seconds for each question. So you read the question, you click. Not only getting the answer right, the quickest finger will also count, and that's how you get the marks. And Kahoot will keep displaying who is on the top, how much you need to catch up, and all that. So it is fun. And this is one thing I really love that Dr. Pankaj has done, making study fun. Okay, guys. So I think now, how many do we have? We have
one more thing. Dr. Pankaj has just now, about an hour back, he promised gifts for the top 2 scorers of each episode. So we'll be asking the top 2 scorers to put in their emails and their names to us so that we can send across their gifts. And we'll be having these quizzes every month, 3rd Thursday of every month, same time. And then the final Kahoot quiz would be in the month of November, whereby we would be having the top scorers of all the 10 episodes, and then maybe the central team can work out real big incentive for them, maybe a chance to attend for division. So I think we get going, and it's going to be real interesting and fun, and a lot of incentive as well. So for the next time, you can be telling more of your colleagues to be with us. That's all I have to say. Thank you.
So we have 20 people logged in.
Hani Qureshi is installing, so maybe she wants a minute.
Yes.
Rekha, no, she's asking for. Because once we have the people in, he'll be locking the Kahoot room, right?
Yes. So
we have 23 people with us so far.
Yes.
Should we start, Dr. Padmaja?
How many do we have?
23.
So, if anyone is else logging in, please tell us in your chat box.
Yeah. Hani Qureshi, are you able to install it, or do we wait for you?
Yeah, in this 23, it is one of them is me, so it is 22 participants. I was just giving it a try. Okay, just we'll give a minute and then we will start. Okay. Dr. Priya has given such a lovely talk. I mean, both the talks were very good, so I think they will get most of them correct. So it will be the quickest finger that is getting it, because they will know the answers. Yeah, I think.
We have 25 people so far, and 8:22, Honey wrote that she needs a minute. I think we can wait another 2 minutes for her to I don't know him or her. We can wait 2 minutes more for Hani to be doing it.
So I think for everyone, install your Kahoot previously itself for the quiz so that you don't have to install it now. And then you just have to put in the pin and get ready.
Meghna, please install with your mobile number. Please install with the mobile number. So Hani is ready. Yeah.
Yes.
So we have 25 people.
Yes. So you can lock it. Shivam? So welcome everyone to the first quiz in season 2. And here we go. All are signs of tuberculosis except have peritoneal windows, blue python, kissing tubes, freely patent tubes. We're looking for signs. Yes, we have most of you correct. And that was the quickest finger. So you need to be fast. On laparoscopy, probable finding of female genital tuberculosis include all except. The word is probable and this is an exception. Straw-colored fluid, abdominopelvic adhesions, caseous nodule, convoluted and hyperemic tubes. The right answer is caseous nodule because nodule is not probable, it is diagnostic. Okay. So the next question. WHO recommendation of anti-tuberculous treatment in drug-sensitive extrapulmonary tuberculosis. 6 months, 9 months, 12 months, 18 months. Excellent. Most of you have it correct. It is just 6 months. So don't prolong the agony. TB, anti-tuberculosis is very difficult to take. Next question, please. Menstrual abnormalities in late female genital tuberculosis include all except. Excellent, menorrhagia. So menorrhagia, just now Dr. Priya had told us it is an early sign of endometritis. Next, please. So we have the marks pretty close. Next, please. Composite reference standard to detect genital tuberculosis includes gene expert, MRI, CT scan, HSG finding of block tubes. That's perfectly correct. Gene expert. We've been talking about it all through this session. And we have 9 players who reached the answer street 3. So there's a tough competition going on. Positive Montos is diagnostic of tuberculosis. True or false? False. That's where. So most of you have it correct. It cannot even be used as a screening test now. Which of these statements is true in detection of tuberculosis? PCR has poor sensitivity, high specificity. Gene expert, high specificity, low sensitivity. PCR, poor sensitivity, poor specificity. Gene expert, high specificity, high sensitivity. Gene expert is highly specific but not very sensitive. You just heard Dr. Priya tell that she had only 4 or 5 positive out of 4,000 cases. So it is very specific. In female genital tuberculosis, tubes are affected 70%, endometrium 90, ovaries 25. Tubes 25, endometrium 70, ovary 90. Tubes 90, endometrium 70, ovary 25. Yes, most of you have it correct. The tubes are on 90%, endometrium 70%, and ovaries 25. Commonest clinical feature of cervical tuberculosis. We don't mean this cervical, we mean our uterus and cervix. Cervical tuberculosis. Finding of a tubercle, pustule, ulcer, or polypoidal growth or a nodule. Shivam, has this frozen? It's not moving. Yeah, we didn't get the answer. It is an ulcer because it has cervical tuberculosis is a great mimic, and it has been sometimes mistaken for cervical cancer also. Ulcer or polypoidal growth. Next, please. Hysteroscopy findings of endometrial tuberculosis include all except pale looking cavity, tubercle, small white caseous nodule, polyp. Correct. Polyp is the answer because polyps, micropolyps can happen, but polyps with tuberculosis are very rare. We are moving on to the questions on endometriosis. Prevalence of endometriosis with Mullerian abnormalities, 10, 20, 30, 40%. %, is the right answer. Because this is the overall picture. Next, please. Risk of endometriosis when first degree relative has endometriosis is higher by 2, 5, 7, 10 times. Seven times. Dr. Pratap always says when you don't know anything, say 10, but unfortunately, number 10 does not hold here. 10 rules of 10 centimeter cervix. Here it is 7. Next question, please. Cytokines involved in implantation, proliferation, angiogenesis in endometriosis include all except interleukin, monocyte chemotactic factor, ranitidine, fibroblast growth factor. Fibroblast growth factor is the wrong answer. I thought it is just different enough to say that. So whoever has guessed that, most probably it is a guesswork itself. Next, please. Protective factors to prevent endometriosis. Early age of menarche, short menstrual cycle, heavy menstrual bleeding, diet rich in vegetables and fruits. So most of you are going to be talking to your endometriosis people, right? By telling them to increase their vegetable and fruit intake. Next, please. CA125 in endometriosis has high sensitivity specificity, true or false? Excellent. I'm very glad that almost all of you got this right. So CA125 is not used to diagnose endometriosis. Next, please. Deep endometriosis is defined as endometriosis infiltrating greater than what depth? 3, 5, 7, 9 millimeters. Most of you got it right, 5 millimeters. Next. You just heard about endometriosis fertility score. It includes all except NZN, LF, AFS endometriosis score, AFS total score. Excellent. NZN is for deep infiltrating. Next. Cancers that are more common in women with endometriosis. So you have the various options: the ovarian, clear cell, cervical, ovarian, clear cell, uterine, non-Hodgkin's, colon. The one that is most common is ovarian, clear cells, and non-Hodgkin's lymphoma. It's not uterine cancer. Next, please. So this was a tough round. That's what Kuhut is saying, because 7 players lost it, their answering streak. This you must be good to go. Dynogest is a 19 not testosterone derivative. Which generation progesterone is it? First, second, third, fourth? Fourth generation. Most of you have it right. So this is the last question. Assisted hatching improves pregnancy rate and implantation in assisted reproduction for endometriosis. True or false? False. I'm glad that most of you got it right. So the pregnancy that has to occur will happen. Assisted hatching for endometriosis does not improve implantation rate. So congratulations to the winners. Congratulations to all the participants. And can we have so the third is, and this is not, there's not much difference in the marks, but glad to see the winners. So if you can write in the chat box your names and email addresses, it will be great. The 3 winners.
Thank you so much, Padmaja. I'm really impressed by the variety of questions that you have brought us, and really brain-teasing ones. Hard work you must put in into having such interesting questions. Really
Yeah.
have-
Yeah.
I mean, if I learned so much, the participants must have really read. And I would request Shivam to please note down the numbers from the chat box of the winners, because Pankaj has promised prizes to be delivered on their address.
Yes, we need.
Saying something, Padma?
Yeah, we just have these numbers. I'm noting them down.
How sweet.
Yeah.
And I can see our zonal coordinators with us. I can see Dr. Vidya. I can see Dr. Shikha from Guwahati. Can I request
Uh,
that
yeah, thank you, Dr. Manjusha. Your voice is not clear. First of all, I would like to thank this for Dr. Manjusha and for organizing this session in such a short time, in such a good way. I would like to thank Dr. Manjusha. First of all, I would like to thank our President, Dr. Pankaj Talwar sir, Dr. Shweta Mittal ma'am, Dr. Geeta Khanna ma'am, and Dr. Ritu Khanna, who have joined and have given their this shared our knowledge and who have made this session interactive and give their blessings to us in this and they have given their valuable time. I would like to thank Dr. Pankaj Salwar sir and Dr. Shweta Mittal sir, and thanks Dr. Geeta Khanna ma'am and Dr. Ritu Khanna for joining this session and making us interactive. I would like to thank our speakers, Dr. Shweta Gupta ma'am, who has given such a wonderful talk on endometriosis and infertility. I would also like to thank Dr. Priya Bhave, who has given her deliberation on genital tuberculosis, which is always a dilemma in front of all the delegates and all the gynecologists. I would like to thank Dr. Padmaja for organizing this session and conducting this quiz session in such an interactive way and making it alert and making it active and making it session so interactive. I would also like to thank Dr. this at IT team for making this session and event possible. Thank you all. Thank you again.
With your permission, ma'am, should we end this meeting?
Just a minute. I'm taking a picture of this. Yes.
Yeah, please.
Yeah, you can please. You can.
Thank you, ma'am. Thank you very much, ma'am.
Thank you. Good night and have a nice evening.